as a topic of my report is mutual concomitance of pancytopenia and chronic heart failure in patients infected with human immunodeficiency virus. My research team, not large. There are my teacher, my mentor, who grew me since the 19 years old as a doctor, Michael Zubarev. He is 84 years old now. He's sitting at home, but usually we often meet and advise, and it is great. And my second co-author is Emmanuel Abiago. He's a great professor, the best professor of Africa, the main hematologist of Africa, and he interested in the same topic, and we collaborate with him very successfully. And my third co-author, Vladimir Zholobov. Vladimir Zholobov is hematologist, cardiologist, professor of internal disease polyclinic therapy department, great scientist, and my inspirator too. And my three co-authors were respect professors, all three. And let me start. About 38 million people worldwide were registered with HIV infection. It is a great spread infection in all the world, many years yet. HIV cases multifactorial organ damage, progressing to acquired immunodeficiency syndrome with severe multi-organ failure. This virus affects cardiomyocytes and bone marrow cells early, leading to cytopenias such as anemia, thrombocytopenia, leukopenia, and pancytopenia, which is linked to decreased survival. This study explores the relationship between pancytopenia and chronic heart failure in HIV-infected patients treated in a large urban hospital. Study aim and design. Study aim to investigate how pancytopenia influences chronic heart failure manifestation in HIV-infected patients. Conducted in a large Russian hospital, it was an exploratory one-stage cross-sectional screening involving 240 hospitalized HIV patients over 4 years in 2018-2022. The study followed the Declaration of Helsinki Principles with voluntary informed consent from participants. Inclusion required confirmed HIV immunoblood and patient consent, excluding those with oncopathology, severe comorbidities, valve defect, or refusal to participate. I will say some later about this. Study type, exploratory cross-sectional screening design, 240 HIV patients during 4 years, and the ethics concern was get for agreement of ethics committee of university where I'm working, Perm State Medical University, Russia, Perm City. Diagnosis criteria for chronic heart failure and pancytopenia. Chronic heart failure diagnosis followed by Russian Society of Cardiology guideline, requiring the clinical symptoms and signs, systolic and diastolic dysfunction in echocardiography, and level of NT-proBNP equal or more than 125 picogram per liter. Pancytopenia was defined by simultaneous anemia, thrombocytopenia, and leukopenia. Anemia was hemoglobin below 120 grams per liter in women, 130 in men. Thrombocytopenia was platelet count under 100 to 150, but this index is individual for every country, for every population. It is different, depend from race and geographic position. It is very interesting. As leukopenia too. Leukopenia more depend from geographic, race, age, pregnancy, and other. And in our country, leukopenia level under the 4. Among 240 patients, 160 had chronic heart failure. It is 66.7% of patients hospitalized with different reasons in hospital, 160 from them with chronic heart failure. Inside of this group was with pancytopenia, 63%, it is 37.4 showing pancytopenia, and 97% without. And next design was compare different indexes between these two groups, with pancytopenia and without pancytopenia inside the group of patients with HIV and chronic heart failure. And of course, we got some interesting data due to this investigation. Cardiac assessment method. I myself, a doctor, ultrasound diagnostic, cardiologist, and observed all these patients in machine YV-T8 with method of Simpson. I estimate the ejection fraction level, left ventricle ejection fraction by Simpson, more comfortable to measure than another method. Diastolic dysfunction was assessed via transmittal flow and tissue Doppler imaging. And additionally, for estimation of diastolic dysfunction was used the TEI index, myocardial index. It was calculated to clarify diastolic dysfunction to additional index. Left ventricle hypertrophy was confirmed by increased left ventricle mass index exceeding 115 grams per meter square in mean and 95 grams per meter square in volume. And all these together, all these three was a moment of echo diagnostic of chronic heart failure. Biochemical markers, if you understand that all patient was in a hospital, usual markers in everybody was took. It is CBC, urinalysis, chemistry. It is all was in everybody. But additionally to everyone was performed analysis of NT-proBNP, indicator of cardiac stress, C-reactive protein, marker of systemic inflammation, and TIMP1, reflect tissue remodeling activity index. It is a very important new marker. NT-proBNP levels and C-reactive proteins levels were measured with use of chemical reagents vector-based Russia for immunoenzyme kits, immunoassay. Tissue metalloproteinase 1, it is a TAIMP1, were also assessed via immunoenzyme assays, but I used chemical reagents from China, Sanlong Biotech company, very good company. These biomarkers help to evaluate cardiac stress, inflammation, and tissue remodeling in HIV patients with chronic heart failure and pancytopenia. Statistical method used in the study, that analyzed with Statistica 13, it is a Russian program, and IBM SPSS Statistic 26, it is an American program, USA, and both of them add each other very good, very comfortable to work with, the both present. A distribution was assessed by Kolmogorov-Smirnov criteria and Shapiro-Wilks test, revealing non-normal distribution. Results are presented as medians with quartiles or percentages. Statistical significance was set as p less than 0.05. Mann-Whitney and Mann-Whitney test and Xi-square test compared group was used. Spearman method assessed correlation, and ROC analysis and truth ratio analysis evaluate prognostic value. And here we can see the main method for investigation. Сейчас I will decrease a little the picture because top not visible. Clinical characteristics of groups of patients with chronic heart failure depending on the presence of pancytopenia. On this picture, you can see that some trends present but not present good P. We can see that little more male gender, a little more smoker, less alcohol, more coronary artery disease, little more ventricle rhythm disorders, not different antiretrovirus European groups, how many patients in one group, how many in another, so quite similar. Here not present different, but only some trends. Not present different, but from another side, present some different. What kind? If you will look functional classes assessment by New York classification of chronic heart failure, In group of pancytopenia was more patient with more higher functional classes than in group without pancytopenia. And totally p level equals 0.001. Another index, it is clinical assessment scale scores. In Russia, and now it is used in many countries, to present special clinical assessment scale for measurement of severity of heart failure. It was modified by academician Mariev in Moscow and using more than 20 years, very successful. But it's possible to use in any other patient bed, not depend from severity of patient, because many answers take doctor himself. And of course, in this scale was different, grade different. And also very good known for everybody 6-minute walk test. The 6-minute walk test was a difference between group 2 and in pancytopenia less meters patient walked than without pancytopenia. Of course, we understand it, but it is a figure, it is statistic. Next, my results are changes in blood pressure in patients with chronic heart failure and HIV and depending on presence of pancytopenia. And of course, usual blood pressure monitoring revealed that in group of pancytopenia was both more high as systolic blood pressure as diastolic blood pressure, both indexes was more high. In pancytopenia, mean pancytopenia impact on this. Next moment, summarize that clinical difference present with pancytopenia, mostly with the severity of chronic heart failure. Severity of chronic heart failure more intensive. Patients with pancytopenia show more higher functional class and clinical scores. And low 6-minute walking test distance indicate reduced exercise capacity. Of course, these indications are very important for clinical clinical signs, clinical symptoms of this disease. And in blood pressure, different demonstrates that more patients with arterial hypertension and more higher level of arterial BP present in persons with pancytopenia. Maybe it is not arterial hypertension, but not hypotension. Arterial hypotension present too a lot in pancytopenia persons, but it is a topic of next research. But here we are different that yes, more higher level was in patient with pancytopenia, of course. Next moment present about non-invasive angiography findings. We used Hungary equipment, tensiomet, which measure special indexes. Just next slide will be about this equipment, but this slide about diastolic dysfunction. Higher ratio E to E little demonstrate that was more patient with diastolic dysfunction, and diastolic dysfunction in group of patients with pancytopenia was more bright. And their index the same, but more clear, different, we can see. In pancytopenia, worsening diastolic dysfunction in comparison with a patient without pancytopenia. It is interesting. Here we can see some indexes of non-invasive arteriography. What this device, how it looking? Name of this tensiomet arteriograph 24 Hungary. And this device, of course, very easy to use in a hospital because not difficult apps for this. Just I will move it towards this. And you can see a report from device. The device give report and they represent some different. We can measure stiffness of wall of aorta and brachial artery, large arteries. Also, we can measure brachial artery pressure, and aortic artery pressure, pulse wave velocity, and augmentation indexes, altogether indication of stiffness. And we can see that was a difference between level of systolic blood pressure inside aorta, level very clear. Was index augmentation in iota was different, not a lot, because it was not a great different to say. But we can see pulse pressure in iota different. More higher pulse pressure in iota in patient with pancytopenia. And pulse wave velocity was a little higher in patient with pancytopenia than in patient without it. And in conclusion, increased aortic systolic pressure and pulse wave velocity reflect more pronounced large vessel stiffness in patient with pancytopenia. Laboratory parameter differences. Here I tried the main only. We have a lot of figures, but only the main. That not overload my presentation, my speech. What I saw, that level of NT-proBNP, index of severity of heart failure, of indication of heart failure, was more higher in patient with pancytopenia. You can see the level of P 0018. TIMP1 level in a serum was more higher, in 2 parts more higher inside the pancytopenia group. C-reactive protein 1.5 more higher in group of pancytopenia. That means all this was together with inflammatory process. But level of CD4 T lymphocytes was less in group of pancytopenia. That means pancytopenia is a mask of immunodeficiency. Hemoglobin level was less. In all group was anemia, but hemoglobin level was less in group with pancytopenia than without. Leukocytes level was less a lot in group of pancytopenia. Platelets level was less, but I investigated level of thrombocytopenia inside the group of patient with HIV, which is agreed to. The lymphocytes level not different. Band neutrophils level not different, but segmented neutrophils was different, was less in patient with pancytopenia. Eosinophils level was not different. That means the main difference, what I found, higher in pancytopenia level of NT-proBNP, level of TIMP1, CRP, and erythrocyte sedimentation rate did not index it, but it was high too. Low in pancytopenia hemoglobin level, leukocytes, platelets, and CD4 T lymphocytes. No significant difference between eosinophils, lymphocytes, and except CD4, CD4 is the main index of immunodeficiency in HIV patient, and it was significantly lower in group of pancytopenia. Next, inflammation and immune status. Inflammatory markers like CRP and erythrocyte sedimentation rate levels higher in some pancytopenia patient indicating inflammation. Immune cells CD4 T lymphocytes significantly lower, showing immune suppression. And we can see combination of inflammation and immune suppression. But there was no any difference in my patient between taking of antiretrovirus therapy treatment, no different. Not a lot of patient was in my group with antiretrovirus therapy treatment, not a lot, very little amount, all on the naive HIV duration, mostly. Also was revealed correlations, interesting correlations with chronic heart failure severity. Hemoglobin level inversely correlated with NT-proBNP level. We can see the ranges with T index, with Eich ratio, platelets and leukocytes level correlation was moderate with NT-proBNP and T index. Segmented neutrophils level was correlated with NT-proBNP and diastolic dysfunction indexes, and inverse with body mass index, segmented neutrophils. And of course, these findings demonstrate for us that present a great connection, great collaboration between bone marrow and heart in patient with HIV infection. And now we demonstrate for you ROC analysis curve, which show that NT-proBNP predict pancytopenia with 70% of sensitivity and 63% of specificity. And we found the threshold value. It is 300.4 picograms per milliliter. High levels indicate bone marrow damage risk in HIV patient. That is why analysis of NT-proBNP in plasma or in serum, they're relatively similar, no present ranges. We took it. There are possible prognosis, as represent indication of bone marrow damage or not, and it is absolutely new. There are no such workers that it is present a level. And it is an odds ratio. Results: risk of cardiovascular disease in patient with pancytopenia rise in 12.3 times. Patients with pancytopenia have 12.3 times higher risk of cardiovascular disease. And moderate correlation present between pancytopenia and chronic heart failure. These two figures I put in one slide because they are most important. They're most important. That pancytopenia in 12.3 times rise risk of cardiovascular disease. Next moment. Conclusion and next directions. The study highlights a significant relationship between chronic heart failure and bone marrow dysfunction manifested as pancytopenia in HIV patient. Understanding the shared pathophysiological mechanisms involving viral infect, inflammation, and immunodeficiency is crucial. Further research is needed to clarify these mechanisms and improve clinical management of HIV patients with chronic heart failure and pancytopenia. These findings emphasize the importance of integrative cardiac and hematological assessment of HIV care to enhance patient outcomes. And the main point, the manifestation of chronic heart failure and pancytopenia as a marker of medullary hematopoiesis insufficiency in patients with HIV infection are closely related to the common pathogenetic mechanisms of the virus. It's shown that aggravation of chronic heart failure in HIV-infected patients is observed against the background of pancytopenia. Clinical changes are manifested in the decrease of 6-minute walk test, indicated and the detection of more severe functional classes of chronic heart failure. Echo result confirms the aggravation of diastolic dysfunction in the indices. The ratio of peaks of maximal airway filling velocity of the left ventricle to airway diastolic velocity of the fibrosis ring, and TAI index in patient with pancytopenia on the background of chronic heart failure. Non-invasive angiography demonstrates higher values of office blood pressure, aortic pulse wave velocity, and pulse pressure in patients with chronic heart failure with pancytopenia. And later I will continue that higher level of NT-proBNP in chronic heart failure with pancytopenia indicates greater severity of chronic heart failure. Increased values of tissue metalloproteinase 1 in chronic heart failure with pancytopenia indicate active fibrotic process of HIV target organs, endothelium, myocardium, and bone marrow. These processes are also influenced by the inflammatory response, as evidenced by high levels of C-reactive proteins and erythrocyte sedimentation rate. General blood tests are performed in all patients with HIV infection, so pancytopenia may detect it more quickly than chronic heart failure in patient with HIV infection. In pancytopenia is detected in this patient, we recommended a 6-minute walk test, echocardiography, and plasma and NT-proBNP concentration to prevent the development of chronic heart failure. This is a close mutual conjugation of the processes of cardiovascular disease formation in pancytopenia in patient with HIV infection. The chance of cardiovascular disease development in patient with pancytopenia, especially chronic heart failure, rise in 12.3 times. The level of NT-proBNP is equal or more than 300.4 picograms per milliliter. It is possible to predict the presence of pancytopenia as a marker of bone marrow damage in HIV-infected person. On this level, I want to say first thank you for your attention. On this peak, you can see one of the most beautiful places of our region. It is the Ursula Pillars. View us in Avatar film, amazing. Come as a tourist to our region, Perm, Russia, because they represent very beautiful places like this. When I worked with my favorite Indian student, we 2 times visited these places, and they said, wow, we did not see it anywhere more. Thank you very much. I was very glad demonstrate for you result of my investigation. I hope that one day I will finish it and will defend my dissertation. Oh, this thank you very much. If somebody have a questions, please ask.